Now, in this part, we will discuss the benign soft tissue lesions. We start with hemangioma. Hemangioma is the most common tumor of infancy and childhood. The lesion is uncommon in bone and gives the coarse trabecular pattern seen in X-ray. In vertebral bodies, you should remember the jailhouse vertebra. In soft tissue, often present with the mass that fluctuates inside and with pain that waxes and wanes, especially with activity. On X-ray, you may see mineralization in the soft tissue, often a benign-looking periosteal reaction if the lesion is close to the bone, and usually see bright, wormy patterns in T2 MRI, with a mixed T1 picture of dark areas and area of fatty signals. The lesion frequently is found in the muscle. Benign may excise if very symptomatic, but recurrence is a problem. Percutaneous sclerosis of lesion with ethylene oxide is a favored treatment of choice, but must be done under anesthesia. Capital lesion in juveniles often spontaneously regress. Histology will show varying size of thick and thin wall blood vessels infiltrating through the tissue. Remember that there are a wide variety of subtypes, but in exam generally they ask about intramuscular lesions or bony lesions, usually in the vertebral body. Concerning lipoma or benign fatty lesions, generally shown as intramuscular masses. These are typically asymptomatic. Histology shows mature, uniform adipocytes without significant stranding or much cellularity. Signals always follow the fat at all images modalities, and perhaps the most modest stranding seen on CT or MRI in intramuscular lesions. They are diagnosed with imaging alone, as their appearance is distinct and they are determined lesions. Benign schwannomas. They are seen in all ages, mostly between 2nd to 5th decade, and they have a predilection for the flexor surfaces of the upper and lower extremities. They are slow growing and asymptomatic, often present for several years prior to the diagnosis, usually attached to the nerve, but it does spare the bundles of nerves and hence can be removed without sacrificing the nerve. There is a difference between neurofibroma and schwannoma. Even if some of the lesion needs to be left behind in an effort to save the nerve, recurrence is rare. MRI show focal, well-circumscribed lesion, which is very bright in T2 and mixed signal in T1, and at the target appearance. Histology show verrucae bodies, nuclear palisading with Antony A and Antony B areas of the tumor. Antony A are cellular, Antony B are myxoid. They are often associated with mutation affecting NF2 gene. Treatment is simple excision without jeopardizing the nerve. Similarly, now neurofibroma is another peripheral nerve sheath tumor. If solitary, show up as superficial lesion in 2nd and 3rd decade. They are generally slow-growing, painless lesions that may have some neural entrapment type. Histology show loose, wavy, elongated cells with strands like collagen and mucoid material. In the larger nerve, these are fusiform in shape and travel some distance along the nerve. The lesion is in the nerve, and unless a cystic portion exists separately, one cannot generally remove the lesion without sacrificing the nerve. Talking about neurofibromatosis is a genetic disease. Type 1 is peripheral with cafe-olate spots, multiple lesions, axillary fracking, Lish nodules of the iris. We have to refer this to ophthalmologist for assessment. It can have tibial pseudoarthrosis. Remember the classification and association. Neurofibrillin is the gene product which is defective in NF type 1. and is chromosomal 17 abnormality. Type 2 is a central form with bilateral 8th nerve neurofibromas and associated with NF2, and abnormality is chromosome 22. Patients generally with neurofibromatosis get plexiform neurofibromas and can get elephantiasis neuromatosa, redundant hyperpigmented skin, and are increased risk of developing malignant peripheral nerve sheath tumor. The risk is about 5%. In 50% of malignant peripheral nerve sheath tumor cases arises from underlying neurofibroma. The other 50% are spontaneous mutations. The histology will show sweeping fascicles of fibrosarcoma. Prognosis of the sarcoma is poor, less than 20% survival at 5 years. Treatment is resection and radiation. Now we'll concentrate towards malignant soft tissue lesions. So soft tissue sarcomas that spread to the regional lymph node include rhabdomyosarcoma, synovial sarcoma, clear cell sarcoma, and epithelioid sarcoma. So these are the soft tissue malignant lesions which can spread to the lymph node. I will repeat again: rhabdomyosarcoma, synovial cell sarcoma, clear cell sarcoma, and epithelioid sarcoma. Chemotherapy appears to be effective in rhabdomyosarcoma and synovial sarcoma, but is not proven in most other soft tissue sarcomas. But this can be given if there is systemic disease. Unplanned excision of a soft tissue sarcoma or delay in diagnosis generally has a negative impact on quality of life of the patient. Synovial cell sarcoma. It's the most common soft tissue sarcoma of the lower extremity, but can occur in upper extremities as well. Also common in young adults, often long-standing prior to discovery. Despite the name is rarely a lesion of the joint, soft tissue mass may be cystic appearance or on imaging studies, often in multiple fluid levels and minimal surrounding tissue changes. Mineralization of soft tissue on X-ray is common. Similar thing of mineralization of soft tissue happens in liposarcoma as well. Synovial cell sarcoma is common in thigh and the shoulder girdle with a relatively poor prognosis at 10%. Some 25% of the lesion will have lymphatic spread and nodal disease. This is much higher than most soft tissue sarcomas. Mets are present in some 30 to 60% of patients, mostly often to the lung. Surgical treatment and radiotherapy is given later on. In some cases, you can give chemo as well, especially in those situations where systemic disease is present. Histology may show monophasic or biphasic spindle cell and epithelial cells population. The translocation is X-18 and commonly tested. Immunochemistry is positive for vimentin, keratin, and epithelial membrane antigen. Now, talking about fibrosarcoma, it's a sarcoma of older population. They can occur virtually in any location, but most common in lower extremities. High-grade spindle cell sarcoma is the most common soft tissue sarcoma in adult. Histology is pleomorphic and storiform in high-grade spindle cell lesions. In fibrosarcoma, histology will show a herringbone pattern of spindle cells. Treatment is surgery and radiotherapy in soft tissue. Prognosis is poor overall, rarely manifest as superficial lesion, less than 5%, which is better prognosis. Leiomyosarcoma. It's an aggressive soft tissue sarcoma, often seen in retroperitoneum. Really, these lesions may arise from vascular smooth muscles and present in bone. These are smooth muscle sarcomas that in extremities are likely associated with blood vessels. So histology normally shows blunt cigar-shaped nuclei in cell with abundant pink cytoplasm. These stain positive for desmin, actin, which are muscle markers, and positive for vimentin, which is sarcoma marker. Treatment is wide excision and radiotherapy. Prognosis is poor overall. Then we talk about epithelioid sarcoma. In exam, it's mostly in the hand or the forearm, aggressive tumor of the young adult, and often mistaken for benign granulomatous process. They can be deep or superficial and have calcification present on imaging. These are nodular on histology with epithelial appearance and lot of eosinophilic cytoplasm on high power. Wide resection and radiation is often necessary, but beware of regional lymph node metastasis. Prognosis is overall poor, mostly require amputation. Talk about clear cell sarcoma. Very common, seen around the feet of a young adult between 2nd to 4th decade, although can be found in upper extremities as well. It is dark lesion, usually deep-seated and often intimately associated with the tendons. It usually shows on the dorsum of the foot as opposed to the melanoma, which is plantar to the foot, and is very aggressive lesion. Prognosis is poor. This stain positive with S100 and HMB45. Chromosome translocation is 11:22. The etiology of this lesion is felt to be neuroectodermal. Treatment is frequently amputation plus minus chemo. Now, rhabdomyosarcoma. It's the soft tissue sarcoma of the children under the age of 15. It is frequently seen in adults. While embryonal subtype is overall most common type and seen in children, an alveolar type is a subtype which is most commonly seen in extremities. A pleomorphic subtype is most common in adults. Treatment is chemo, resection, and occasionally radiotherapy. Must look at the marrow and do a marrow aspirate in these cases, as it may spread to it as well. Prognosis varies but can be good in young kids with focal disease, and this is one of the few soft tissue sarcomas where the chemo is the standard. So that's the difference between the soft tissue sarcoma and rhabdomyosarcoma. All others, we don't rely on chemo, but in rhabdomyosarcoma we rely on chemo. Stain positive with vimentin, desmin, and myosin. May have somewhat of round cell appearance in pathology. Then we talk about liposarcoma. This is the most common soft tissue sarcoma overall. Usually present between age 4 to 6 decade. These are usually deep lesions, most commonly situated in deep thigh or the retroperitoneum. Well differentiated variant is the most common type. The lesion may mineralize, likely like synovial cell sarcoma. The lesion may metastasize to the retroperitoneum. A myxoid liposarcoma, the chromosomal translocation is 12:16. Treatment of liposarcoma is resection and radiotherapy. Liposarcomas has different type and can vary from well differentiated to low grade lesion to a high grade aggressive pleomorphic lesion. Lipomas. So lipoma, if it is shown in images, will be likely a sequence of fat and a subcutaneous or in a muscle. The liposarcoma will not follow fat signals on images, so it will be completely different. Fibromatosis, desmoid tumor. It's a fairly common lesion, mostly arising in the abdominal wall, and the extra-abdominal lesion is usually seen by the orthopedic surgeons. Some 30% of the patient has history of trauma to the site of occurrence, including prior surgery. Uncertain if this is associated with the etiology or not. Patient present with a mass, only about half presenting with pain. the lesion is present for a long time before treatment. The shoulder region is the most common site. Histology showed dense spindle cells in a row with variable collagen and hyalinization. Lesions are dark to minimally bright on MRI. These lesions are difficult to treat, and NSAIDs or chemotherapy is strongly considered for larger lesions which are not amenable to simple resection. Recurrence is common, 20% following resection, which is why there is a trend towards less surgery. If surgery is performed, the goal is wide margins and consideration of radiotherapy is often given. Now we talk about the lesion of the joints, PVNS. It's a tenosynovial giant cell lesion associated with the major joints, most commonly the knee. It is characterized by a mass effect with a slowly growing lesion that becomes painful as it affects the joint. X-ray show erosive changes around the joint, sometimes even large cystic destruction. MRI show mass effect in the joint that has mixed signal on T1 and T2. Histology shows synovial cells, hemosiderin, giant cells, all growing into a cleft-like pattern in the tissue, with a collagen capsule that surrounds and pervades the lesion. Treatment is by simple excision in focal nodular disease and extensive synovectomy attempted in diffuse disease, but recurrence is common. May respond to low-dose radiation or intra-articular radionuclide treatment following excision of gross disease, particularly in case of recurrence. Histologically, you should also remember that giant cell tumor of the tendon sheath in the hand has similar histology like a PVNS and is very commonly painless mass that's slowly growing and restrict motion. The treatment of giant cell tumor of tendon sheath is simple excision and is generally effective. Synovial chondromatosis. Synovial chondromatosis is a metaplastic changes in the synovial tissue that causes the formation of chondrite bodies in the joint, usually knee or the hip, often in nothing to see on X-ray, unless lesions are mineralized, and then it is called synovial osteochondromatosis. MRI show fluid with synovium and multiple loose bodies in the joints, looks like marbles in the joint. Grossly looks like a popcorn in the joint. Histology show hyaline cartilage surrounding by collagen and spindle cells, all benign looking. Pain in the joint is a presenting feature. Treatment is removal of the loose bodies and synovectomy as appropriate. Recurrence is common, but the process can burn itself out with time. Often the joint starts to show signs of arthritic changes. Really, this disease can progress to synovial chondrosarcoma. Some rare things we have to discuss. Osteopoiculosis, autosomal dominant condition consisting of multiple small to medium sized bone islands in cancellous bone. Usually asymptomatic, they are generally cold on bone scan. Differential diagnoses include metastatic carcinoma, which should be hot on bone scan. No treatment is indicated. Myelodystosis. This is a non-genetic condition that has the appearance of melted wax dripping down a candle. This can either be industrial or cortical in location and often only one side of the bone. This lesion typically affects the long bones, while usually asymptomatic in children. It may be painful in the adults. Bone scan is typically hot. There is a reported association with fibromatosis. The etiology is unknown, and the treatment, which is non-specific, is directed at problems of the involved bone or associated soft tissue. Soft tissue lesions. Some of the organisms which is important associated with the disease should be remembered, such as Lyme disease is Borrelia burgdorferi, human bite Echinella cordons, domestic animal bite Posterella multicida, and cat scratches fever caused by Patronella henselae.